Good morning, and thank you very much for inviting me to be part of this symposium. In the next minutes, I'm going to present a real example of a counterfactual prediction of causal inference in health research. To start, let me go back to the first months of 2020. As we all remember, the COVID-19 pandemic left us with images of empty cities like this one of Puerta del Sol, which is one of the most famous squares in Madrid, in Spain. At that time, there was an urgent need to find effective drugs to prevent and treat COVID-19. And tenofovir disoproxil fumarate, TDF, an inexpensive generic drug used for more than 20 years to prevent or treat HIV and hepatitis B, was considered as a potential option. What I'm going to show you is a collaborative work we did in Spain to assess whether TDF was effective against COVID-19. And I'll do that following the steps of causal inference. Because of that, let me start by telling you how this causal question arose. Well, Spain is one of the European Union countries with the highest burden of HIV disease. Estimates are that around 150,000 people are living with HIV in the country. Now, what are the characteristics of people with HIV in Spain? Well, they are mainly men who, thanks to the antiretroviral treatment, are getting older. Among those 50 years or older, 24% have relevant comorbidities. Besides, they experience immunosuppression and accelerated aging. Because of their characteristics, when the COVID-19 pandemic emerged, health authorities, researchers, clinicians, scientific societies, patients' organizations, and NGOs were concerned about the potential impact that this new pandemic could have on people with HIV. As we all remember, risk factors for severe COVID were male sex, older age, and the presence of relevant comorbidities like hypertension, diabetes, chronic pulmonary disease, and kidney disease, all of which were common among people with HIV, as we've just seen. Because of that, what we expected was that people with HIV developed severe COVID. However, we didn't observe an increased risk of severe COVID in people with HIV treated with antiretrovirals. This observation led us to hypothesize that the use of antiretroviral treatment could reduce the risk of severe COVID. And it was possible, as in Spain, almost 97% of people diagnosed with HIV receive antiretroviral treatment, most often to nucleoside reverse transcriptase inhibitors, NRTIs, plus a third drug. And there was evidence from preclinical data suggesting that NRTIs, and in particular TDF, could be effective against SARS-CoV-2. Furthermore, TDF had been suggested as treatment for SARS-CoV-1. In an attempt to elucidate whether TDF was effective against SARS-CoV-2, the Ministry of Health called upon a series of a group of stakeholders with access to data and expert knowledge needed to answer this causal question. Who were involved? Well, researchers from Vera, which is Spain's best network for cooperative research in biomedicine, researchers and the HIV surveillance team from the National Center for Epidemiology at the Institute of Health Carlos III, which is the top Institute of Health in Spain, Miguel Hernan, with whom we've been working on causal inference for many years, but also the Spanish Medicines Agency, the Spanish Coordination Center for Alerts and Health Emergencies, clinicians and scientific societies and patients' organizations. I play my part as a researcher from Vera, in which the largest platform of people with HIV in Spain, the CORIS cohort which I lead, is integrated, but also as a researcher of the Institute of Health, Carlos III. What did we do? Well, we did a randomized trial of pre-exposure prophylaxis with TDF among health workers, but also 2 observational studies which I will explain. In the first study, we could describe the incidence, clinical severity, and mortality of COVID-19 by NRTI combination. And in the second study, we used causal methods with appropriate adjustment for confounding to assess the causal effect of TDF on the risk of severe COVID-19. We carried out the first study between February to April 2020, which were the hardest months of the pandemic in Spain, with a lot of effort and the collaboration of 60 HIV clinics in Spain. We could collect information on sex, age, and antiretroviral regime on COVID-19 cases among people with HIV on antiretroviral treatment. At that time, we couldn't collect any other individual information. In fact, we had to use the National HIV Hospital Survey to approximate the distribution of sex, age, and ART regimes of all people with HIV on ART. This first study was published in 2020, and what did we learn from data? Well, among 77,000 people with HIV on antiretroviral treatment, we found that TDF users had about half the risk of COVID-19 hospitalization than users of other antiretrovirals. And how can we interpret this result? We know that TDF may produce renal toxicity, and because of that, is usually prescribed to individuals with no renal toxicity or other comorbidities, thus to healthier individuals with a lower pre-existing risk of severe COVID. And we knew that to know whether this lower risk of hospitalization in TDF users reflect a causally protective effect or simply confound it, we needed to adjust for potential confounders like comorbidities. But as I previously said, at that time, we couldn't collect any other individual information. And this is the reason why, some months later, when the COVID-19 pandemic in Spain was stabilized and the hospitals were less overwhelmed, we decided to conduct a second observational study identifying, collecting, measuring, and adjusting for potential confounders like comorbidities. I will explain this study. Our goal in this study was to emulate a target trial in which individuals are randomly assigned to a particular NRTI combination before the start of SARS-CoV-2 transmission in their communities. We included HIV-positive individuals aged 18 years or older who on February 1st, 2020 were on antiretroviral therapy, had virological suppression, and had not received a diagnosis of SARS-CoV-2 infection. Antiretroviral regimes were classified by NRTI combination in these 4 groups, and our outcomes of interest were hospitalization, ICU admission, and death due to COVID-19. And for each individual, follow-up started on 1st February 2020 and ended on 31st December. We estimated the 48-week risks for the different outcomes in each NRTI combination and compared them with risk differences and with ratios. Which data systems did we use to emulate this target trial? Well, we used data from the COVID collaboration in Spain, a collaboration of 69 hospitals in Spain. And to be able to adjust for potential confounders, we asked clinicians which were the factors they used to channel individuals to either TDF or other drugs. And following experts' criteria, we collected information on the comorbidities you have in the slide. Each participating hospitals collected this information from their clinical records and transmitted the identified data to the coordinating center at the National Center for Epidemiology. To adjust for identified and measured confounding factors, we used probability, inverse probability weighting. We estimated the denominators of the weights using a multinomial logistic model for the 4 NRTI combinations with the covariates you have in this slide, including all these comorbidities. And it is important to know that the application of these weights to the study population creates a pseudo-population in which confounders are equally distributed across NRTI combinations. Let me show you the results of this study. Here you have the selection of individuals from the emulation of the target trial. We included 51,000 eligible individuals. 12% of those were receiving TDF. Here you have the baseline characteristics by NRTI combination, and as we can imagine, there were differences in socio-demographic and clinical characteristics according to NRTI combination. Let's look, for example, at comorbidities, and as we expected, individuals in the TDF group had lower prevalence of hypertension, diabetes, and chronic renal disease than individuals in the other groups. As I said, we used causal methods, inverse probability weighting, to adjust for these potential confounders, and here you have the adjusted results. Here you have results for hospitalization. In the graph, you have the 48-week risks by NRTI combination, TDF in yellow, and in the table you have the number of events, risks, risk differences, and risk ratios. And as you can see, individuals receiving TDF had a lower risk of hospitalization than other users. We found a similar pattern for ICU admission. TDF users had a lower risk of ICU admission, and we found the same for death, although here results were very imprecise. We did a subgroup analysis for hospitalization, and as you can see in this table, among individuals 50 years or older, we found a lower risk of hospitalization among those receiving TDF. Well, to summarize the results of the second study, we studied over 50,000 HIV-positive individuals on ART with adequate virological control in Spain during 2020, before the start of the SARS-CoV-2 vaccination campaign. The estimated risks of COVID-19 hospitalization and ICU admission were lower among individuals treated with TDF, and this potential benefit of TDF appeared to be restricted to individuals over 50 years or older. We used inverse probability weighting to adjust for potential confounders, but residual confounding, but yet to be identified factors cannot be excluded. However, we think that such a residual confounding seems unlikely because we adjusted for all known comorbidities that affect both the antiretroviral treatment choice and the COVID-19 severity. And how did our results compare to other studies? Well, our estimates were consistent with other observational studies carried out in Spain, but also with observational studies did in South Africa and the United States. To conclude, I would like to say that despite the observational evidence suggesting favorable COVID-19 outcomes among TDF users, TDF never received emergency use approval. Most observational studies with appropriate adjustment for comorbidities were published when the SARS-CoV-2 vaccines were available. And, well, in the Spanish case, if in the first study we carried out during the hardest months of the pandemic, we had had access to individual data on comorbidities, perhaps the impact of our results on clinical practice would have been different. Thank you very much.